A very good morning, my dear students. Hope you are all safe and studying at home. My topic for today's class is female genital tuberculosis. In a country like India, genital tuberculosis continues to be a major gynecological problem, presenting with varied clinical symptoms like infertility, chronic pelvic pain, chronic pelvic masses, as well as abnormal uterine bleeding. In this context, it becomes very important that we know how to evaluate, diagnose, and manage female genital tuberculosis, which is still an underdiagnosed condition in Indian scenario. Tuberculosis continues to be an important major public health problem in India, and if you look at the chart, you can appreciate that the major contributor of tuberculosis cases across the globe is by India, that is around 21. If you look at the burden of tuberculosis in India, it is very scary. About 40% of Indian population have latent tuberculosis, and out of this, 1 in 10 patients will develop an active tuberculosis. The case fatality rate of tuberculosis is quite high as 45%, and concomitant HIV increases the case fatality rate to 95%. Multi-drug resistant cases is a new addition to the burden of tuberculosis, which is to the amount of 11.5%. Let us revise our knowledge about tuberculosis. You all know tuberculosis is an infectious disease caused by Mycobacterium tuberculosis, and the primary organ of affection is lungs. So there is a pulmonary tuberculosis and extrapulmonary tuberculosis. So amongst the extrapulmonary tuberculosis, we have meningeal tuberculosis, genital tuberculosis, gastrointestinal and peritoneal tuberculosis, urinary system, bone, and lymph. Genital tuberculosis gains more significance because it has a toughest diagnostic challenge to the treating clinician. Female genital tuberculosis is always a secondary tuberculosis, and only 5 to 13% of pulmonary tuberculosis patients develop female genital tuberculosis. It is very interesting to know that the female genital tract becomes susceptible to Mycobacterium tuberculosis immediately in the postmenopausal phase. At this stage, let us understand two terminologies: pelvic tuberculosis and genital tuberculosis. Pelvic tuberculosis and genital tuberculosis are not synonymous, though the female genital organs are situated in the pelvis. Pelvic tuberculosis usually means involvement of the pelvic peritoneum, the pelvic and the mesenteric lymph nodes without any involvement of the female genital tract. And genital tuberculosis means involvement of the female genital tract. But in majority of the clinical scenarios, there will be an overlap of female genital tuberculosis and pelvic tuberculosis. Female genital tuberculosis poses a stiffest diagnostic challenge to the gynecologist because of its varied clinical presentation, diverse results on imaging and laparoscopy and histopathological examination, a mixed bag of bacteriological and serological tests, and it is called a great mimicker in terms of clinical presentation as well as in terms of the interpretation of the investigation reports. The exact prevalence of female genital tuberculosis is unknown because of the varied clinical presentation and the challenges faced in diagnosis. However, in infertility clinics, India has a prevalence of 19% compared to less than 5% worldwide. This again signifies the burden of female genital tuberculosis in India. Coming to etiopathophysiology of female genital tuberculosis, as you know, female genital tuberculosis is a secondary tuberculosis, almost always secondary to a primary focus in the lungs. Sometimes the latent tuberculosis, which is prevalent in 40% of Indian population, can get reactivated later in life in situations where the general immunity is depressed, like in Hodgkin's lymphoma, AIDS, steroids, stress, and malnutrition. Let us understand the etiopathophysiology of female genital tuberculosis. The mode of spread from a primary focus, usually from the lungs, is through hematogenous route, and fallopian tubes are the commonest genital organs which are involved with tuberculosis. Sometimes the spread can occur through lymphatics, which is evidenced in bovine strain by the ingestion of raw milk through the gastrointestinal tract. Rarely, a direct spread through the sexual partners can be the source of infection, which usually involves the cervix, vagina, and vulva. This is evidenced by the prevalence of active genitourinary tuberculosis in 4% of husbands of females having female genital tuberculosis. As I said, the female genital tract is more susceptible to Mycobacterium tuberculosis infection in the postmenarchal age group, and more so if the active primary infection occurs during the pubertal age group. Let's see the frequency of involvement of female genital organs with tuberculosis. As you can see, always fallopian tubes are involved in 100% of cases of female genital tuberculosis. The next most frequent organ would be the endometrium, ovaries, cervix and vagina, and vulva is the rare site of involvement due to female genital tuberculosis. The first evidence of infection occurs in the fallopian tube, and in the acute phase, the fallopian tube show exudative salpingitis. Subsequently, the tubes become studded with tubercles, and then they start getting densely adhered to the adjacent organs in a chronic phase. Further involvement of uterus, the endometrium and ovaries occurs by direct spread. Endometrium is the second most common site of involvement in female genital tuberculosis. You see a scattered involvement of the endometrium studded with tubercles most of the time, and the shed endometrium is reinfected by the lurching infection in the fallopian tubes. Sometimes the endometrium can be totally damaged and become atrophic in 2.5% of the cases, resulting in amenorrhea. This is a picture of the fallopian tubes in the acute phase leading to exudative salpingitis, then studded with tubercles leading to adhesion formation and involvement of the endometrium by tuberculosis. As I said already, female genital tuberculosis is a great clinical mimicker presenting with varied clinical signs and symptoms. Therefore, highest index of clinical suspicion is extremely important to arrive at the clinical diagnosis. Remember, majority of the women are in the reproductive age group, though you get patients even in the postmenarchal age group. Very few patients come in the postmenopausal age group. 20% of the women with female genital tuberculosis will give a family history of tuberculosis, and 30 to 50% will give you a history of having had some form of tuberculosis or having taken anti-tubercular treatment. So coming to the clinical presentation of female genital tuberculosis, the systemic clinical presentations are more or less similar to primary pulmonary tuberculosis, like poor health, loss of appetite, loss of weight, undue fatigue, and low-grade fever. Coming to the more specific symptoms related to gynecology, infertility is the most frequent presenting symptom of female genital tuberculosis, where 85% of the females present for the first time with the history of infertility. After infertility, patients of female genital tuberculosis can present to the gynecologist with some other gynecological complaints like menstrual disturbances. The most common menstrual disturbance is infrequent cycles associated with less bleeding. However, around 20% of the patients, especially in the acute phase, can have menorrhagia, and around 14% of patients can present to you with primary or secondary amenorrhea in the late stage of the disease. Lower abdominal pain is also a frequent complaint noted in around 50% of the patients. Tuberculosis is one of the important causes of chronic pelvic pain and dyspareunia. Vaginal discharge and postcoital bleeding can also be a presenting complaint of female genital tuberculosis, especially in women with local lesions in the vagina and cervix. Coming to the clinical signs in cases of female genital tuberculosis, actually there are no specific clinical signs which clinch the clinical diagnosis of pelvic tuberculosis. Most of the time, the clinical evaluation is normal in 35 to 50% of the cases. You may find a pelvic mass. There could be pyometra, that is nothing but collection of pus in the endometrial cavity. Adnexal mass and tenderness can be there, like in cases of chronic pelvic inflammatory disease. Ascites can be there if female genital tuberculosis is associated with pelvic tuberculosis. There could be excessive vaginal discharge with some ulcerating lesions in the vagina or cervix. Sometimes patient can present with signs and symptoms of acute pelvic infection, which is called as flaring up of the latent genital tuberculosis. This can occur in the background of a superimposed bacterial infection of the female genital tract, surgical trauma like patient has undergone a procedure like a DNC or a copper T incision, or when patient is advised to undergo HST for evaluation, the latent genital tuberculosis can flare up and present as acute pelvic inflammatory disease symptoms. Sometimes late and neglected untreated cases can present to you with utrovesical, tubointestinal or tuboperitoneal fistulas. Genital tuberculosis can mimic ovarian malignancy, and sometimes CA125 can also be raised in cases of genital tuberculosis. As you understood that there were no specific symptoms or signs which clinch the diagnosis of female genital tuberculosis, still the saying holds good that a highest index of clinical suspicion is required to arrive at the diagnosis of female genital tuberculosis. So you should always suspect female genital tuberculosis in cases of unexplained infertility, in women coming with signs and symptoms of chronic pelvic inflammatory disease refractory to the standard CDC recommended treatment, and in young females presenting with adnexal mass and ascites. Coming to diagnosis of suspected case of female genital tuberculosis. Routine investigations like CBC and urine are of little importance because counts are usually normal. Only sometimes ESR may be raised, and urine microscopy can show abacteriotic pyuria in concomitant urogenital tuberculosis. Though genital tuberculosis is most of the time secondary to a primary pulmonary focus, chest X-ray also may not be of help in confirming the diagnosis, as prior evidence of pulmonary tuberculosis is present only in 10 to 50% of the cases, and simultaneous active pulmonary tuberculosis and genital tuberculosis are rare. Coming to Monto test for diagnosis of female genital tuberculosis, a positive test is read as a discrete wheel of more than 10 millimeters between 48 to 78 hours. But however, it is also not 100% sensitive or specific, especially in Indian population where most of them are immunized with BCG. Coming to a little more specific tests to confirm the diagnosis of female genital tuberculosis. The first one in the list is menstrual blood for AFB smear. It is a simple test, but however, it is positive only in 10% of the cases, and it is not specific because any other acid-fast bacilli may be mistaken for Mycobacterium tuberculosis. Endometrial curettage for histopathological confirmation and culture for Mycobacterium tuberculosis is a more specific investigation compared to the menstrual blood AFP. This should be the first diagnostic test which should be done in cases of suspected female genital tuberculosis. The timing of endometrial sampling is very important because the endometrium has to be sampled in the late secretory phase or the premenstrual phase. This is because the tubercles would have reached the surface of the thick endometrium. So the endometrium is subjected either for Mycobacterium tuberculosis isolation or for histopathological examination for evidence of central caseating granulomas. Apart from the timing of endometrial biopsy, even the site of curettage is also important, as corneal curettage leaves at least 50% possibility of histological diagnosis, because tubes are always almost 100% involved in cases of female genital tuberculosis. Therefore, the histological yield of granulomatous lesions in the endometrium increases if the site of curettage is from the cornea. Positive cultures are seen in 25% of the cases. There could be cases where you get a false negative report due to sampling error, and a negative report does not exclude the diagnosis of female genital tuberculosis. Culture of Mycobacterium tuberculosis from the endometrium sample or from blood and serous fluids can be an alternative method of confirming the diagnosis, but because of the time taken, these tests are not usually done in the first attempt. Histosalpingography has classical signs which are diagnostic of female genital tuberculosis, but however, we never do an HST to confirm the diagnosis. In fact, doing an HST should be deferred if you are suspecting pelvic tuberculosis due to the possibility of flaring up of latent genital tuberculosis. But however, in the investigation of infertile couple, whenever an HST is done without any doubt about pelvic tuberculosis, classical signs on HST can be diagnostic of female genital tuberculosis. The findings on HST which are pathognomic of female genital tuberculosis are bilateral corneal block, the rigid lead pipe appearance of the tubes, irregular endometrial cavity with calcified tubes, extravasation of the radio-opaque dye into the vessels. So this is the terminal hydrosalpinx seen in the tube, which looks like a tobacco pouch appearance, which is also pathognomic of female genital tuberculosis. So in nutshell, presence of bilateral tubal block, rigid lead pipe appearance of the tubes, irregular endometrium, calcification of the tubes, extravasation of the dye, and tobacco pouch appearance of the tube. These are the pathognomic findings of female genital tuberculosis if the lady is subjected for an HST. Remember, never do HST in a suspected case of female genital tuberculosis in order to confirm the diagnosis. Hysteroscopy is one of the more specific investigations which you can offer in cases of suspected female genital tuberculosis. So the findings on hysteroscopy which are suggestive of tuberculosis which require further confirmation are irregular or small uterine cavity, intrauterine adhesions, scanty endometrium, endometrial calcification, caseation or tubercles, periosteal fibrosis, caseous material coming out of the ostia or ostia not getting visualized. In all such cases, you need to collect the endometrial sample and send it for histopathological confirmation or isolation of Mycobacterium tuberculosis. Similar to hysteroscopy, laparoscopy is also a specific diagnostic method in the evaluation of female genital tuberculosis, though it is invasive. The findings which are suspicious of female genital tuberculosis are adhesions, pelvic congestion, tubercles, frozen pelvis, edematous inflamed tubes, beaded appearance of the tubes, presence of tubo-ovarian masses, or straw-colored fluid in the pouch of pelvis. So if you find any of these findings on laparoscopy, please collect the tissue specimen and send it for confirmation by histology or by isolation of Mycobacterium tuberculosis. This is a laparoscopic image of a case of severely affected genital as well as pelvic tuberculosis. You can see how the tubes are inflamed, and in the entire uterus the tubes are studded with the tubercles, including the pelvic peritoneum and even the surface of the bowel. The most difficult challenge in confirming the diagnosis of female genital tuberculosis is the demonstration of Mycobacterium tuberculosis from the specimen collected either by endometrial sampling or hysteroscopy or laparoscopy. The earlier methods of isolation of Mycobacterial tuberculosis in the form of AFB smear and culture are not sensitive. So there is a high possibility of false negative report. Recently, detection and identification of Mycobacterium from the clinical specimens is being done by the genetic methods like PCR or nucleic acid assays. These molecular tests have made the diagnosis of tuberculosis a little more sensitive and as well as less time consuming, and the two most important tests are detection of the genetic material of Mycobacterium tuberculosis by either a PCR test or by a nucleic acid assay test, which is called as TB-NAT. So this real-time PCR can be done on any of the samples which is collected from the patient suspicious of tuberculosis, depending upon the site of suspected tuberculosis. The rapid molecular tests, that is PCR or TB-NAT, have their own drawbacks of false positive as well as false negative results. False positive results are usually due to non-tubercular mycobacteria, and false negative reports could be due to sampling error, blood contamination, paucibacillary tuberculosis, PCR inhibitors, or ineffective primers. So, in a clinical scenario, when you have a strong clinical suspicion of female genital tuberculosis, and if the PCR comes as negative, either you should repeat a tissue sampling or go for a different diagnostic technique. The second rapid molecular diagnostic test, that is nucleic acid assay based test, which we call it as TB-NAT, is also an alternative to PCR, but however this test is more reliable only when there are a lot of bacilli in the sample. Compared to histopathology and Mycobacterium tuberculosis culture, the rapid molecular tests have an advantage of that the reports usually come within 2 to 3 days. There is another latest addition of investigation which we call it as TB Gold or quantiferon. This measures the immune reactivity to Mycobacterium tuberculosis, which is assessed by interferons which are released by T sensitized cells after stimulation with Mycobacterium tuberculosis antigen. Quantiferon or TB Gold test is the only test which is FDA approved for detection of tuberculosis, and remember this is the test which uses the peripheral blood for detection of interferon against Mycobacterium tuberculosis irrespective of the site of lesion. As you saw, there are a battery of investigations right from menstrual blood for AFB smear to quantiferon, which are used to establish a clear-cut diagnosis of female genital tuberculosis. When we compare these diagnostic tests, laparoscopically acquired sample along with the PCR test has the best specificity and sensitivity in picking up female genital tuberculosis. Establishing the diagnosis of female genital tuberculosis is really a challenge in the presence of so many investigations with various sensitivity and specificity and the difficulty of acquiring the proper tissue for diagnosis. But once the diagnosis is confirmed as female genital tuberculosis, the treatment is very simple and straightforward. The main modality of treatment is medical, where we treat the patient initially with 4 drugs for 2 months, that is INH, rifampicin, pyrazinamide, ethambutol or streptomycin, and the maintenance therapy usually is a little more prolonged compared to pulmonary tuberculosis, where the maintenance therapy can extend up to 6 to 9 months. This slide shows in detail about the anti-tubercular drugs which are used along with their dosages as per kg body weight, both in the initial as well as in the maintenance phase. Compliance to the treatment and completion of treatment is extremely important for better outcome with anti-tubercular therapy. Following medical treatment for female genital tuberculosis, histological cure is usually achieved between 1 month to 3 months interval. Compliance is of utmost importance to prevent drug resistance as well as optimal outcome to the medical treatment. In spite of the treatment, recurrence of cases can occur within 2 to 5 years of completion of ATT, and if accidentally any operative case is diagnosed as tuberculosis histopathologically, then immediately such patients have to be started on ATT in the post-operative period, and the treatment may be continued for 6 to 12 months depending upon the case. Coming to the role of surgery in the management of female genital tuberculosis. The role of surgery is limited because if the patient is compliant and the treatment is properly completed for the adequate duration of time, most of the patients respond well medically. Only in few cases we may have to resort to surgical treatment. The indications for managing female genital tuberculosis surgically are persistent or recurrent disease in spite of full and adequate medical treatment, recurrence of pelvic masses, recurrent pelvic pain and abdominal uterine bleeding, non-healing fistulas and concomitant malignancy. With this, we come to the end of the topic of female genital tuberculosis. As you all know, female genital tuberculosis is a problem which causes a lot of gynecological problems in females, right from infertility to chronic pelvic pain, menstrual disorders, and chronic pelvic inflammatory disease. And most of the time it is underdiagnosed. There are no specific clinical features or signs suggestive of female genital tuberculosis. Female genital tuberculosis does not have any specific or clinching clinical symptoms or signs, so therefore it is called a great mimicker, clinical mimicker. Strong clinical suspicion is the key to diagnosis. In the investigative workup, routine blood test, Monto test, and smear and histology and culture pick up very few cases. TB PCR, TB NAT, TB Gold tests have increased the pickup rate and reduced the time required to make the definitive diagnosis of female pelvic tuberculosis. Medical management is the first line of therapy in female genital tuberculosis. Compliance and completion of therapy is essential to prevent drug resistance and recurrence. Surgical therapy is chosen as a second line of therapy only in select cases. Thank you.